right, we'll go ahead and kick off our webinar today, From Mandate to Momentum, Building Value-Based Enterprises for Team Model Success. It's presented by Pinnacle's team. They are a Team Connect corporate sponsor. Team Connect, for those that are not members, is a community where we are fostering collaborations, shared insights. It's free for hospitals and ACOs to join. Our membership, we launched February 21st. We've grown to 80 plus site members representing 60 participating hospitals. We host member-only roundtable discussions, webinars, forums, and online resources. So please check it out if you have not. As an example, here are the several different webinars we've hosted on a monthly basis. Great insights provided by experts in the field. Today, we're going to learn about value-based enterprises. We have scheduled our July 10th roundtable. We'll be discussing more around the team data and insights and what others are doing with the data they've received from CMS, as well as the governance structure and value-based enterprises. So continue the discussion July 10th. You can sign up. If you have not, it's members only. You can go navigate to the members tab on apmconnect.com and then select roundtables to register. We will be scheduling July, August, and September webinars coming up, and we are looking to host webinars specific to each bundle. So really diving clinically into some of these bundle episodes, and we look forward to that. So look for more information to come. If you are interested in presenting, feel free to contact us. I'll put our email address in the chat. But without further ado, I am going to introduce our speakers. It's my pleasure to introduce our speakers today. Anthony is a fellow in American College of Healthcare Executives. Prior to joining Pinnacle, Anthony gained over 30 years of healthcare experience. Anthony served as a director of health strategy with Navigant Consulting and executive vice president. With these companies, he has led numerous hospital physician and practice strategic alignments, private equity acquisitions, along with several strategic service line planning efforts for large health systems and hospitals. Anthony also specializes in cost-saving initiatives involving supply chain management. Working collaboratively with all stakeholders, he has generated several millions of dollars in revenue and savings. Prior to consulting, Anthony served as the president of Multi-Heart Hospital Centers and as a senior executive for 6 Hospital Health Alliance in the Midwest. Anthony is a regular speaker and a published contributor to the national programs, including American College of Healthcare Executive, American Academy of Medical Administrators, American College of Cardiovascular Administrators, and the Healthcare Financial Management Association. He holds an MBA with an emphasis in health administration and a BS in business administration. Jim has a very diverse background within healthcare industry, spanning nearly 35 years, providing clinical care, strategic planning, operations management, strategic sales, and leadership. Jim is recognized as a strong strategic thinking problem solver and a C-suite trusted advisor. Jim is retired principal from a top 20 leading professional services firm offering assurance, tax, and advisory services for clients in all 50 states and was responsible for oversight of the Cleveland, Ohio office. During his retirement, Jim formed his own professional advisory firm, J Advisory Services, that focused on assisting his clients empower smart growth and sustainability, and is now part of Pinnacle Healthcare Consulting. Jim has an experience in all areas of healthcare strategy, physician alignment, operations improvement, merger and acquisition, physician practice planning, employed medical group development, AMC, faculty practice planning, radiology services, and hospital leadership. He has also spent time at the Philips Healthcare in an enterprise business development role and at GE Healthcare, where he was a black belt in Six Sigma, Lean, and a master change agent. Jim also has a strong clinical skills from his time as a registered medical technologist. We are pleased to hear from these two experts today in the value-based enterprise field and from Pinnacle. Thank you so much, Anthony and Jim, for joining us, and we look forward to the presentation.
Yeah, thank you so much, Rhian. And I really appreciate and grateful to participate today as we go through and talk about really kind of a range of topics. We'll start by talking about alignment. Jim will walk us through just the alternatives. So part of the conversation today and frankly, the majority of the time is going to be spent on value-based enterprise models, VBEs, and some of the opportunities that we have to work in that structure. And then we'll talk about just some alignment associated with team and the opportunities that we see in utilizing the VBE model. There certainly are other models that we'll talk about, Jim will cover, and then we'll talk about just engagement and alignment of stakeholders. And for some of you, that's between the health system, the ACO, physician groups. I think you'll hear us consistently throughout the presentation just talking about the importance of engaging, involving clinicians, physicians throughout those efforts. So with that, let's kind of jump in. Feel free to ask questions. I know the chat sections are going to be monitored throughout the presentation this morning, but feel free to drop questions in there, interrupt, give us a little yell if you have a question. But with that, let me turn it over, Jim, to you, and we'll jump into the presentation.
Thanks, Anthony, and thanks everyone for joining today. If you think about going back to the Affordable Care Act and basically in 2010, hospitals and physicians have been working together for a very long time. You can go ahead and go to that next slide, Anthony. There's been a lot of work, again, even going back before the Affordable Care Act, when it's all about obviously increasing quality and decreasing cost, moving from volume to value. Post Affordable Care Act, it's no surprise that hospitals and physicians generally need to continue to collaborate and work together to be successful, especially in the bundled payment models, CJR models, and now teams. Obviously, with the Affordable Care Act and the start of accountable care organizations, if you look over to the far right, what we call an advanced hospital physician alignment model, I've had the opportunity to work with hospitals and physicians on every one of these types of models. Many of these models are still working today, everything from gain sharing to co-management that you see in the center there. Employment is still alive and well. Many physicians, well over 70+%, are employed by some entity, which could be payers, it could be health systems, and private equity. We are looking at some of what we're calling our advanced models with the value-based enterprise. And really I wanted to say, I think it was in 2021 of January 21, CMS came up with some exceptions in Stark Law and Anti-Kickback statutes that allows for further collaboration without as much scrutiny, for example, maybe in a co-management type of arrangement that allows innovation. And, this structure has been around for a few years. It hasn't been adopted by many. It is starting to get much more attention because it really is a great organizational model that you'll learn that can, quite frankly, house all of your population-based health initiatives and serve as that infrastructure to move you forward. So what it is, if you keep going, next slide. Great, Anthony. It's really around shared incentives and working with your physicians around the vision. Teams model has very bright vision for, those selected in the 5 categories of the clinical areas. Building trust with your physicians, collaborating together, developing those relationships are really all core components of any kind of hospital physician alignment model. So as we talk about the value-based enterprise, right, we still need to be mindful. It's not the magic bullet. It is not our golden ticket to do what we would like to do with our physicians without guidelines. And it is not our get out of jail free card, right? There are still lots of activities in those areas being monitored by the government in these types of relationships. So it's imperative that you also work with legal counsel on all of these matters. We are not giving you any legal advice today, so just wanted to be clear on that. But just with that backdrop, I'll let Anthony take you guys through the guts of the program, how it was created and the why, and then we'll kind of tie it back to how it could potentially work on a team's environment.
Yeah, thanks, Jim. So I think the critical piece as we start talking about the value-based enterprise, and this really is defined by CMS, is you have to have, first of all, 2 or more VBE participants. So you do have the ability for those to be different types of organizations. It doesn't just have to be a hospital health system and physician practice. You can include payers, you can include ACOs, you can incorporate some different components. We'll talk about later in the presentation. We'll talk about who can't be part of those, or at least some limitations that you have. But this really was a model that was put forth by CMS to say, hey, we want you VBE participants to be innovative, to think about and have conversations about items that maybe you've spoken about before, maybe you've attempted to address, but either the federal guidelines got in the way of that, or the structure of those arrangements didn't allow you to be as creative as the VBE positions you to be. So the first aspect is you've got to have a value-based purchase, and we're going to go through each of these in a bit more detail to explain them. You also have to have a value-based arrangement. So kind of a misnomer is this doesn't require you to set up a separate corporation. You don't have to go through and stand up a large structure in order to make it happen, but you do have to have some components that are important. So there is a legal document that is associated with this, with the VBE. You have to have an accountable body, and this gets a lot of different terminology. So some will call this simply as it's stated here, the accountable body. Others will say it's a board. Others will say it's an advisory board. It's less important what you call it. The key is that you've got to have an oversight, an overseeing body that is evaluating and actually guiding the efforts behind the VBE. And then you also have to have that governing document that explains work plans, performance criteria you're looking to achieve, and just some of that criteria that lays out very clearly. So as we go through and we talk today, the intent would be to not only talk about the structure and what's in place, but also talking about and making sure that there's clarity about opportunities that we see in working together with the team concept and the mandatory model. So, VBEs, I would say, are emerging. So, the good thing about emerging models is that you still have the ability to create, you still have the ability to innovate. The bad thing about them is that, rules are still being laid out. So they've been laid out by the government. And unlike other models that we implement and we assign kind of on that continuum that Jim removed or discussed on different alignment models, the government this time came out and said, we're not going to write all the rules. We're not going to tell you that your accountable body has to be made up of 6 people. We're not going to tell you that this is how you have to define your population. We're not going to tell you that it has to be every patient in your team model, or maybe it's a model that you focus very specifically on a very defined population. Maybe that's a county, maybe that's a specific payer, maybe that is a specific community within your health system, within your ACO, within the team structure. So it really is intended to be a facilitating risk sharing model. And we'll talk about the different levels of that and what that might look like. But it is intended to be an alignment of incentives, ways to improve patient outcomes, and the opportunity to reduce cost are really the 3 major areas that we're focused on. We think that VBEs are continuing to not only emerge, but really leading models. We've participated in some great innovative conversations between physicians and leadership in, again, whether that's ACOs, health systems, just looking at other ways that we can solve problems and solve creative models for our populations. When we looked at when CMS developed these standards, it really was to lay out how do we do a better job of coordinating care, improving the overall quality. Depending on which level of risk you go and implement, it can include a payer. It does not have to include a payer. And I think that just given the name value-based enterprise, there's an assumption that it has to include a payer. It does not, or it has to include an ACO. It does not. I think that with all of that, while it doesn't have to include, it also can include. And I think really it's just important to kind of define and scale that on the front end. And then it really is about how do we transition from a volume-based environment to a value-based. And we don't have to age ourselves, but for any of you that have been in this industry for as long as we have, I think this conversation has taken place multiple times. It's taken different forms. If you go back to the ACE models, the BIPSI models, gain sharing, there's been different attempts at how do we look at this, and I would say largely that hasn't been for a lack of conversation. It's been for a lack of implementation and or limitations on what that looks like just from an overall model that could be utilized. We think VBE goes quite a bit further in allowing for those conversations to happen. You do have to have a value-based purpose. So again, is your purpose to talk about quality and emphasizing that? Is it coordination of care? Do we have a desire to bring in payers into that conversation? And how do we address the payer side of this without compromising quality for that patient? And then ultimately moving to that value-based model is important. When we talk about activities, this can be really any of the following activities. So are we talking about the delivery or the provision of an item or service, the taking of an action or refraining from taking an action? We will talk repeatedly for any of you that have been involved, as I'm sure probably everyone on this call with CMS. They're very clear. They're not always clear about items, but they're very, very clear that whatever you do in setting up a model like this in a VBE, you cannot reduce care for recipients of Medicare services. And that usually will stretch on to commercial payers as well. But specifically talking about CMS, I think they want to ensure that the reduction of care is simply not an option. So are there opportunities to structure this and look at how we address patients in the ER, how we address patients as they kind of continue through the system? Absolutely. You just can't reduce care overall to those participants. When we talk about a targeted patient population, it really is important to talk about how broad or how limited you want that patient to be or patient population to be. There's some of these that are set up, we can get very, very specific. So maybe you're trying to address a Medicaid or Medi-Cal population in orthopedics. You can get that specific. You can also say that your patient population is spine within orthopedics or total joints within orthopedics, or you can say it's all orthopedic patients. You can say and define it as how team defines that population. So the intent and the takeaway here is that you can make this as broad or as limited as you want to or specific as you want to. The goal, though, when you think about broad, probably the right answer as we're looking at this is not to say every patient that walks through the health system or through your ACO, but rather being specific enough where you're laying out work plans and you're laying out initiatives that are specific enough to a specific patient population. It does have to still be outlined in advance of the arrangement being developed. And then you've got to ensure that however that patient population is defined, that you're talking about how the value-based purpose is aligned with those initiatives. So we have a number of different examples. So again, here we're talking about the concept behind team. That same conversation can be applied with other initiatives and other patient populations throughout your health system or ACO or different environments that you're part of. It does, the enterprise aspect and the accountable body as we go through the next couple slides becomes extremely important. So ensuring that you have an executive committee, an accountable body, a board that is responsible for monitoring the activities. Something that's different in a VBE versus maybe a co-management agreement or some of the other initiatives that Jim spoke about earlier is you do need to outline what your goals are. You don't actually have to achieve those goals. You don't have to improve upon your performance. All of your activities should be focused on that. So we always want to do better than we're doing today. This model, though, doesn't have that requirement in place that you have to actually achieve the outcome. And I know that sounds counterintuitive, and it doesn't mean that you want to extend the offer of this alignment model without achieving those. But federal government came back, and we're going to talk about some of their statements that they made when they were issuing this rule, is that there's not a specific requirement to achieve. We do look at each of these individually and talk about how we improve kind of that overall approach and achievability. You have two different sets of legal guidance. We frequently will talk about the Stark Law exception. We're all familiar with Stark Law, and then you've got the anti-kickback safe harbor consideration. Gold standard and ideal is that from a legal perspective, you're addressing both of these items and that you're not moving away from them, meaning that you're trying to address one without the other. Quite the opposite. In this situation, you really are trying to achieve both. You do have the ability to address AKS and Stark in a no financial risk model. So some have said, we don't know where we're going. We don't know what we're creating from an innovation perspective. We don't ultimately, maybe we don't have the data today to report out, but we want to create that. We want to work with our physicians. We want to work with our teams in order to come up with appropriate monitoring criteria, appropriate care coordination, just overall improvements. But you can say, here's the value for those considerations. This is what we're willing to pay you for participating in those structures without any financial risk at all. You then move up. So I'm starting at the bottom. You then move up and say, we want to establish a meaningful downside risk. That is most commonly structured as a performance pool of dollars. So if you lay out the metrics, you define what it is that you want your team to achieve. It has to be at least 10%. I would say on average, and what we're seeing from organizations, while we do see 10%, majority of organizations have said, I want at least 20 or 30% meaningful downside risk or performance criteria that I want you to achieve with us. And so that is usually set up in a performance pool. You do have the other side on AKS that's a little less specific on what that downside risk is, but you define that and certainly accept kind of that shared risk model as part of those efforts. When we elevate and go all the way up to the full financial risk, this is the alternative where you do include payers into the consideration. You are looking at sharing specific capitated payments or global budgets around care for these patients. And you are looking at what impact does that have for your payer community and or your other shared savings opportunities. So, it becomes kind of important to define up front, are you or are you not going to include a payer? You don't have to end where you start either. So you could start by having a conversation to say, hey, I want to include these individual physicians or this specialty, orthopedics, cardiology, and the team model, neurosurgery, but I want to limit that even further to a very specific model. So again, I think the gold standard is that you work through these and you structure it in a way that meets both Stark and AKS safe harbors. you don't, in to achieve of one side of this equation, you don't have to have a formal valuation in order to establish a payment model. We still think, again, gold standard is that you've got a valuation that validates the overall structure to ensure that it's compliant, but it is not a requirement within the guidelines itself. Again, very different from what we see in other models that we set up. Critical is logic. And I know that sounds simplistic, but this model should not be used at just trying to figure out, hey, how do I push payments and address and get physicians to the table to have a conversation, but rather if you have, and many of you use different forecasting models in-house, but if you have a logic as to, hey, by working together with our physicians, we can reduce the cost of care, improve overall quality, and that translates to a value or a benefit. And then backing off of that to talk about how you're going to share in that savings and or improved outcomes is really what we're looking for. So again, I think from a logic perspective, we want to make sure that we incorporate those items. This is entities. So Stark has one set of guidelines. From an AKS perspective, you can't do VBE and meet the AKS safe harbor if you have a PBM. I'm not going to read these to you, but PBMs, lab corps, entities offering DME, medical device distributors that are not manufacturers. I mean, there are some limitations through this. We have received requests as you go through this model to say, hey, I want to include my distributor, or I want to include a compounding pharmacy. So again, there's just limitations. It's just important to ask the question before you decide how you're going to move forward. So, and then just some quick couple comments on these. There were requests when this was being rolled out for comment period in 2020, there were requests for very specific guidelines. So we always request that the government gives us the ability to be flexible, but then some of these rules come out. I think there's inherently skeptics out there. We're presenting with a large health system that has several dozen of these VBEs in place for different types of services and populations. And, internally, the comment was that senior leadership was always skeptical because the government in this case did not provide clear guidance of what was a population, what was a targeted population, what was a value-based purpose. So these are just a couple of comments back from the government is they went as far as saying, we don't want to limit and create kind of this exhaustive list of how you can use this model. We don't want to be so prescriptive that you're not innovative, that you're not willing to evaluate or work with your physicians, your payer community on coming up with solutions. So again, very different take from the government in rolling this model out than what we've seen historically. So with that, that's a quick introduction. I'm going to turn it over to Jim, to discuss how we see that VBEs can align with the team model, and we'll walk through some of those descriptions.
Thanks, Anthony. Again, that broad overview of the VBE, we're seeing clients use multiple approaches to this, such as service line management, right? It could be orthopedics, neurosciences, or cardiology. Think of it as kind of a co-management agreement on steroids without as much legal rigor. Some of the VBE discussions suggest you don't need to do a fair market value when it comes to compensation for physicians. Some organizations will still do them. It needs to be commercially reasonable, however. So that is one approach. We're also seeing, as Anthony mentioned, some larger organizations are really adopting this model. And, for all of these population health models, right, how do we manage or govern and get our arms around all of the different components? You can imagine how complex it will get. If you have an accountable care organization, you're in, the teams. If you're doing, other population health, RADONC, for example, all of these require leadership. They require physician input. Many of them also require organizations outside of the health system, whether it be skilled nursing and rehab. So how do we manage all of those things? We have data analytics, we have quality. You can imagine, clinically integrated networks, pay for performance. We have all of these initiatives. The VBE could serve as that broad enterprise that could begin to oversee all of your population health efforts. At the end of the day, we've been talking, everybody understands improving operational efficiency, improving quality, allow for some, risk taking. Most of the risk taking is from the VBE itself and not necessarily puts your physicians at risk. So how do we tie that then back to the teams model? And hopefully you've heard these four components. It's a value-based purpose. We need a targeted population. We need to have value-based activities, and we need a properly formed enterprise. Well, we know Teams is an alternative payment model with a value-based purpose. Our targeted population is quite clear, right? On, the surgical procedures and joint procedures and spine. So we have our targeted population from a Teams perspective. There's going to be lots of value-based activities, care coordination and cost reduction. If you think about the financial risk, everyone in the Teams model is going to be at financial risk. So we are meeting many of these criteria as it relates to what the value-based enterprise could help from structurally and organizationally manage your Teams program. The last component, some organizations may or may not have, and that's really setting up the enterprise. So making sure we have the legal documentation, what we're going to work on. Many of the core initiatives will get defined. Many of them will have work plans. We can create separate committees for all of the different types of teams if organizations are pursuing all of those based on what your clinical offerings are. So getting all of these under this legal enterprise is something that working with your legal counsel and an advisor, creating the right committee structures or right rhythm of meetings, of creating an executive committee that would sit over top of all the initiatives. Really, the most senior folks generally would reside on those. So again, it's just not for Teams. We believe it's a great application for Teams. You can use cost savings. We've done these in neurosciences, as I mentioned. These are hopeful and outcomes, right? Reducing average length of stay is a huge infrastructure requirement on some of these, right? Understanding and tying it back to your accountable care organizations. The Teams model definitely wants to try and coordinate that Medicare attribute to your ACO, right? And understanding annual wellness visits, closing gaps in care closure. Again, outside of the Teams program, many of the VBEs really focus on care coordination, right? They're not necessarily doing things at risk at the onset, for example. So how do we successfully implement these, right? There's lots of communication. Many VBE presentations such as this generally take 2 or 3 go-arounds to understand what it is and what it isn't. When you start these, lots of communication, building trust with your participating physicians and or other entities, having a steering committee, clear goals and clinical guidelines, creating clear expectations for what the goals are. In the Teams model, that's pretty clear. Identifying a best practice in some of the committees, of creating a charter. What do we have control of? What don't we have control of? When are we going to meet? What's our goals? What's our baseline data, right? We got to understand with what we're starting with to be able to improve upon. Having the right decision makers at the table who can influence and make change happen. On some of these models, we have the system CEO sit on this executive committee. So we have, and it's very imperative to have the right decision makers in the room. Success factors, like in many other hospital physician alignment models, physician leadership, they have to understand it, buy into it, understand the data, understand the scope, what's in our scope, what's in our control, what is not, allowing physicians to make change happen. That is difficult for some organizations, but if we're going to be successful, we've got to get our physicians involved. What's the compensation of our time and effort? What does that look like? Financial sustainability. We have to make sure that what we're working on is going to improve operational efficiency, thus reducing costs, potentially length of stay, and then performance tracking and data. Imperative for health systems to have the right data analytics component, if you will. So I guess then, Anthony, maybe why don't you take us to what it's going to take from an implementation perspective? What's a successful implementation look like, and wrap us up?
Yeah, so this is implementation is everything. I mean, we all deal with different models. This is really just some important components. So you heard us talk repeatedly throughout this about governance, making sure that there's meaningful roles, not just situations where physicians are asked because you're worried that you're going to upset someone by not inviting them. They have to have meaningful roles. They have to lead the design of care delivery models. Reliable data is critical, and you all work with this, especially on the team model. It's critical that data flow is front and center, that it's understood. Getting data wrong in this situation is simply not an option. I think a critical piece that we sometimes struggle with is not all physicians have to be invited. You want physicians that have the ability to think beyond kind of the traditional models. This is an opportunity to innovate and implement and really just ensure that your physicians are at that table. This is not an administrative, let's push it down and ask the physicians to implement your ideas. This is truly bringing physicians around the table and having them engaged and involved throughout. They will expect, and again, an area that we sometimes get uncomfortable with is the transparency of data. So we throw the conversation about transparency around quite a bit, but actually being able to share that data, including financial data, with the participants is sometimes nerve-wracking and sometimes an obstacle, but definitely needs to be front and center. And then not just from a physician perspective, really talking about how to ensure that all are held accountable. So if that's physician, if that is administrator, but really ensuring that we're achieving aspects throughout this. So I'm going to skip ahead. I mean, certainly as we go through, there's a number of components as we talk about the valuation concept. Very important that everything be commercially reasonable, that it's important. You do have the ability in this model, in our opinion, to really make change, innovate some models that we haven't explored. Looking at how we're addressing and assigning value becomes very important. And that's not just from a valuation perspective. This is really important to kind of talk about what you're receiving collectively overall from a valuation perspective. And then just looking at process and being, wise about implementation, giving folks a chance to participate and really move forward in this model. So again, let me stop here. Let's open it up for questions. Make sure that we have kind of an opportunity just to answer any questions that you all may have as we go through.
Thank you so much, Anthony and Jim. Very insightful information. Please post in the chat or come off mute if you have any questions and raise your hand. I do have a question for you all. As mentioned, the VBE can be a broader scope. So those that are in team, ACO, maybe ACO reach, or also ahead, can you describe some of the benefits? What do you think are the biggest benefits of a VBE model to help across the alignment of those groups and be successful in team?
Yeah, so let me start, and Jim, feel free to jump in. But I think, first of all, there's not limitations. So some of our models are very specific. You can only address inpatient care. You can only address care within a health system. This allows you to actually extend beyond. So you can, it's pre, it's post, it's acute care, it's post-acute care. So your ability to stretch across multiple different types of organizations, but also settings of care in that care coordination, I think is a huge benefit of the model. I think leveraging the work that's already been done in a lot of our organizations around, ACO activities and care coordination and quality outcomes, but leveraging that, in our opinion, the model just gives you a lot greater flexibility to participate and share those experiences, but also be innovative in that actual implementation.
Yeah, I agree with all those comments, Anthony. And a lot of it is also the coordination and understanding of a Medicare beneficiary if they're in the ACO and are going to have one of the procedures in the team model. Let's make sure that internally we have the right information, we have the right decision makers, and that we're coordinating in the true sense of population health, of what we're really looking for. And it's just really the communication between the different components, right? I've seen so many times of silos where your episode of care team doesn't even talk to the ACO team. And I think this can also help bring some of that together. And, the team model having expectations of touching them in an ACO is going to force that. And this structure definitely can help coordinate and bring that together.
We have a question from Victoria. She's asking, how do you see a VBE being implemented between a post-acute and acute care hospitals around the teams model?
Yeah, I think so again, I think we've certainly in the VBEs that have been implemented where we've been part of it, it is kind of moving beyond that traditional setting. Part of that is ensuring that there's just open communication, bringing those post-acute models. So, if that's coordinating with community agencies, if that's long-term care, if that's different organizations, some of that is just thinking through, how are we communicating, your ability to leverage items like transportation, behavioral health services, rehab considerations, things that are just different from a shared risk and reward perspective is really critical as we go forward with post-acute. I think some are better at this than others. So, we work with some health systems that really have no or very limited experience working with post-acute. I think the team model is set up when you're thinking about that 30-day post-op consideration, but even beyond that, really gives you the ability to leverage the goals around those post-acute providers. That can happen both in a remunerated approach, meaning compensation is carried through, but also thinking through just that care coordination aspect of how to implement.
I would see them being yet another participant. If the VBE is specifically set up for team, right? We have to have post-acute providers. And, going back to the days of BIPSI and CJR, getting the data and understanding who your best performers are is a key component. And, until you get your data, or if you've been in those programs, who those providers are, those are going to be someone you would invite to the table, just like the physicians are there and the health system is there, bringing them on to committee work, to an executive committee role. They would be just yet another participant, and a very important one on the outpatient / rehab skilled nursing facility component. As we all know, that's where a lot of our costs come from, and that it's imperative for them to be included in the VBE.
Another question about the entity structure. So just to confirm, a VBE has to be a separate legal entity, or can it be within an existing entity?
Yeah, great question and frequently misunderstood. So it can be within an existing organization, an existing entity. It does not require its own tax ID, does not require a separate corporate structure. It can, and some have said, hey, I want to take this contractually and create that model, but it's not a requirement. Most of this is driven through contractual arrangement, a legal document that guides those efforts. you can certainly set up joint boards and joint governance structures, but it does not require a separate entity.
I don't see any more questions. I would ask, we have some Team Connect members that are brand new to the value-based care space in regards to bundles. And if you have one piece of advice for them, what would be their number one takeaway if they wanted to learn more about VBEs or present it to maybe their leadership?
Jim, you want to start?
Sure. I mean, it's understanding it. As I said earlier, that it's new. It is rather complex, but when you break it apart into those four components, it's very manageable. And it just takes a lot of education and understanding to really get it. And that would be the one, is to continue to learn about VBE. If you've seen one VBE, or if you've seen one type of structure, you've seen one. Every organization have different, ways from a culture perspective, how they manage physicians. So it all really needs to be tailored to your unique situation. And there's no magic bullet, right? And it's really about designing it for what the desired outcomes are going to be. Again, in using the VBE for team, we know exactly what's going to be expected of us. So there's no surprises there. So that's my comment on that one.
Yeah, I think the only other piece I would add to that is, and Jim mentioned earlier, is data is critical, and you may not have the data. Meaning, as we think about different approaches to care delivery, we've been involved in some great conversations between physicians and executives where we just kind of remap, we rethink the conversation. Usually it's you're talking about a back patient that has ended up at the hospital for spine surgery, and then how do you get them back to the practice, or how do you get them to the post-acute provider? How do you work through kind of that care coordination aspect? And it's just not understood because we've never done it that way, or that's not how we do it today. But I think having those conversations, then pulling the data in, so whatever a team definitely outlines that from a structural perspective, but ensuring that data accuracy is there, and ensuring that you're working with your providers to make sure that they've vetted that data and utilize that in some of the solutions is very important.
Thank you both, Jim and Anthony. Really appreciate the conversation in the webinar today. We will post the slides and the recording on Team Connect for members to access and reference. And we can also connect you with Pinnacle. If you have any further questions, feel free to outreach to us. Thank you all for joining. If there's no more questions, we'll look forward to seeing you all July 10th for our roundtable discussion.
Thanks, everybody.
Thank you, everyone.
Have a wonderful day.
For more information, please visit our website, askphc.com. If your organization is part of the mandatory CMS team initiative, you may find the information, resources, and community of Team Connect to be helpful. For more information, visit apmconnect.com.